So good morning and welcome to the instructional course that we are conducting on intraoperative nerve monitoring. We'll focus essentially on thyroid surgery, as is this conference. The way this course is laid out is there's a brief introduction, and then our speakers will speak. Dr. Parthiban will speak on the physiology, electrophysiology of nerve monitoring. I'll speak on data, intraoperative news, and nuances. Dr. Anuja will cover troubleshooting in IONM. Dr. Kostab will talk about the Indian guidelines and their relevance. We'll take questions for each speaker as they finish their talk, so we can ask the relevant questions to the speaker. It's 10 minutes per speaker. We'll take 2 minutes for questions, and then we'll probably have 5 minutes left over at the end. We can do a discussion then, or if you would like, we can do a demonstration of nerve monitoring in the monitor that's available outside in the stall. So while nerve palsy, by and large, if we look at published results, is fairly low, most of these results come from very, very high volume institutes. And if you look at community or real world data, incidence of nerve palsy approaches about 10%. So it's not that rare. We know it's more when you have a high risk pathology, multinodular goiters, revision surgery, large cancers, etc. But actually, no thyroidectomy is safe because it's not only the pathology but the anatomy that can put the nerve at risk. Abnormal, unpredicted nerve anatomy, when looked at, is seen in about a fourth of cases, and these patients are also at risk for potential nerve injury during the operation. We're also very poor at detecting rates of nerve palsy. If we perform routine laryngoscopic exams in all patients following thyroidectomy, we'll find a higher rate of nerve palsy because a lot of nerve palsy presents with very subtle voice changes that is overlooked if we only do symptom-based laryngoscopies. So in a nutshell, nerve palsy is not uncommon. Surgeons are poor at necessarily knowing the rates of nerve palsy. Why do we monitor? That's because accidental transactional injuries of the nerve are actually less common. Most often, when the nerve is hurt, it's by injuries that are invisible or not obvious to the surgeon, from traction, pressure, compression, thermal devices, etc. And to understand how nerve monitoring may help, you need a buy-in to this in this flow chart, which is initially when the nerve is hurt by these invisible injuries, it's going to be subclinical. So the nerve is injured, but the cord function is normal. That, if uncorrected, may lead to temporary vocal cord palsy, and theoretically, if uncorrected, may result in permanent vocal cord palsy. And IONM hopes to stop you at these steps. It hopes to pick up subclinical injury, prevent it moving to temporary, or alerting you to potential temporary cord palsy and helping you reverse it before you reach permanent vocal cord palsy. The data on IONM, though, is controversial of its actual utility. If you look at all published literature, it's very variable in its utility. Some papers showing its help, some doesn't. Where it does help, does look like in temporary vocal cord palsy. There isn't yet proven data robust that says it reduces permanent palsy, but that could also be because that's a very low percentage adverse event. And even then, if you look at the benefit, it seems to be more when you're doing a high risk thyroidectomy. With that intro, I'd like to call Dr. Parthiban, who will then take over and tell us about electrophysiological aspects of ENT.
Thank you, Dr. Sarin. Thank you for the organizers. Good morning to all. Today, I'd like to see that actually electrophysiology and the basic IONM setup, how we can do in this thyroid surgery. No. No. Sorry. Sorry. So we'll start with that. Next. My sincere thanks to our head and neck surgical team as well as my students. Next. So what is intraoperative neurophysiological monitoring is that actually this is the electrophysiological methods to monitor the functional integrity of certain neural structures. It is used to reduce the risk of any patient's iatrogenic damage to the nerve and to provide the functional guidance to the surgeon in a real-time manner. Next. The rationale of IONM is to prevent the new neurological impairment and reassurance to the surgeons about the status of the neurological structures and modify the surgical strategy. Next. So why IONM is needed actually? It's usually the protecting the laryngeal now is a long-term priority and challenge for thyroid surgery, and intervention of rectal laryngeal also more important in these cases, and IONM aids in dissection and helps in the tracing the nerve and progression of the postoperative neural function and lesion site identification. And before we do that IONM, actually we need to know that our gadget, what is it actually exactly it is. It is basically that the surgeon has to know that, and surgeons with neurophysiology anesthesiologists is a extremely coordinated network team to understand and standardize reasonably to apply the IONM techniques. The history of IONM is started in 1966, done by the Professor Donald, and for the pushback, which is published with the idea of rectal laryngeal nerve in 1966 in thyroid surgery. The IONM clinical significance is its facilitates the clinical identification and location of the rectal laryngeal nerve and facilitate the exposure and dissection of the nerve and facilitate the judgment of the functional integrity and the injury mechanisms during the course of surgery. There are many procedures which that IONM definitely which is needed, where it needs is actually dorsal mass, the suspected recent capsular hemorrhage and hypothyroidism, malignant thyroid tumor, reduce cases, and totothyroidectomy during endoscopic surgery to repair their RLN injury, etc. Standard of equipments, you can see that actually electromyography, it's an electromyography based endotracheal tube which is usually preferred to preserve the rectal laryngeal nerve activity, and the neuromonitor system should be able to provide the real-time auditory feedback if possible. This is a similar setup actually we routinely do for our thyroid surgery. Standard set of procedures is quite unique, and it is used to guide and improve the quality of IONM techniques and avoid any adverse effect, and record the vocal cord movement during the course of surgery by using a fiber optic laryngoscope before the surgery, and recommended anesthesia for the IONM also necessary, and body position and the EMG ETG placement also very crucial before start of surgery. And coming to how you are recording, how it looks like is it's a typical EMG evoke potential which is triggered mode. Actually, there are two components here. When you stimulate this, actually stimulus starts and goes to latency. The time travels from start of stimulate point to it is the response, which is the latency, and from the latency where that you are getting the high active action potential, which is called depolarization, called the amplitude. From the base of the latency, start of the end of the latency to the depolarization, it is a peak to peak amplitude, which we usually to measure the course of surgery to predict the interpretation. Next. Basically, how we are recording this biological activity. We have two components in the recording tube. Surface electrodes are actually, one is the active. Next. One is the active electrode. Another one is the reference electrode. And when you're stimulating the active and reference, the potential difference between these two should be different. If you are getting a equal potential, you will get your output of voltage of very zero and you will get a no signal. And if the distance between the muscles between the at least minimum of 2 to 3 centimeters, that should be ideal recording point to elicit the response and try to get the clear potential. which is, you can see that active is a 6 microvolt and reference the 3 microvolt, you will get the difference in the voltage, which is called the real signal, which you can able to record from the vocalist. The another loop is actually the ground loop mechanism, which is more important when we do that thyroid surgery, when you're using the current to stimulate. Next. The loop which comes, the electrical activity which comes, the electrical signal which comes from the main power outlet to the system, from the system which we are delivering the current to the body, and make sure that the current should not stay in the body after you are giving that current to the, now it should not stay in the body, it should come out from the body, so that the ground is always necessary. The ground takes care of that and takes back to the, again the system, and goes back to the main power outlet. In ion thyroid surgery, how to do it? Next, one is a mapping, another one is monitoring. When you do that, stimulating the thyroid, you can get the intermittent nerve monitoring, which is you can get the signal from your vagus as well as electron now. And this device is basically the EMG device, stimulator device is basically the current based. For mapping, constant current stimulation is always preferred. It delivers the preset current stimuli. And the electrical stimulation, you can see that actually it has a unique individual pulse type, pulse width, frequency, how much frequency you are stimulating, how much current you are delivering, what kind of probe that you are using it, everything does matter. We usually do the low frequency with a single trend of 3 to 4 hertz for the electrophysiological method, individual pulse with either monophasic or biphasic. Cathode current is more effective to elicit the response, depolarization state as compared to anodal, and low stimulation intensity is really good enough to see the stimulation effect. And when stimulation probe, when you're using that, actually the electrical current distribution which goes around 360 degree when you're stimulating point and goes and try to map where your nerve structure to elicit the response, so that we are getting a very good amplitude. When you're placing the recording electrode, the EMG ET2 placement, you can see that actually you can place it the EMG ET2 100% exactly in the vocal cord, so that when you're going for the neck extension for the body position, it may come out little bit out, so that the approximately 3/4 of the tube is exactly placed on the vocal cord muscles, so we can easily try to elicit the response. The electrode should be exactly level at the level of glottis. This allows a monitoring of bilateral vocalis muscles surface submitted for depolarization of action potential. The main depth is, you can see there 20 and for the men, and for the woman 19. And you need to check the impedance checkup, which is a less than 5 kilo ohm. You can see that if all impedances are high, the ground electrode should be replaced. You have to check it out, the impedance, and salivary pooling at the level of glottis, you can increase it, that can cause the impedance, so that you will administer drying agent or can minimize the effect, or trying to remove the salivary one. Play the video. This is the illustrative video of how we are placing the ground reference electrode in the sternum. Next one. This is the connecting, where we are connecting the recording jack box, the surface EMG electrodes, which we are connecting in the 2-channel. This is stimulation parameter which we used routinely. Next. This is after we placed everything body position, so we need to make sure that the tube position by using the tap test. You can see that tapping that at the level of glottis, you can see that responses. And the anesthesia is also very more important actually here, that propofol with a less than 1 mEq or inhalation agents can be allowed to continuously monitor the responses. No muscle relaxation should be avoided, as means used after that initial dose. And we can see that the monitoring is actually one is first is the free run EMG, which is, you can see that neurotonic and myotonic discharges, the burst-like activities, you can see that. And the another one is a triggered EMG, which is the advantage of electric stimulating the nerve, which we routinely do the intermittent, recording the CMAPs in the innervated muscles. So this is the typical example of the EBSLN, which you can see that usually EBSLN you will get in a very less potential, very less microvolt, due to that, because there is a far away from the recording electrode, because this is eliciting by the cricothyroid. This is the typical example of the vagus, where we are getting the left side and right side. The left side is always that the latency is a bit high as compared to the right side, vagus. And we have 4 steps actually, B1, B2, R1, R2. the signals to be, how it is detected, we can discuss in the subsequent speakers. Next. There is another technique called continuous intraoperative monitoring, how we are doing it. Next. We have a APS, clip-like stimulator, and how it works. You can see over here in this video. This is superior to intermittent nerve monitoring to preventing the vocal cord palsy. This is our own video recording over there, which you can see there. This is a clip-like video. We can take it and we have to use this clip-like stimulator, which we can apply in the vagus nerve, and continuously we can monitor. This is our typical illustrative video. You can say it allows this APS is visual audience audible recording point from the vocalist muscle. The placement of electrode in saline before the placement of now, actually then finally dissect the vagus and try to apply that. The top corner is our own video, which we have recorded. And use the Alice poster to clip the APS around the vagus nerve and try to slide front and forth to make sure that that is exactly fitted into the nerve. Then you can start your stimulation setup now. So this is our stimulation setup in our OT, and the current flows from the machine to the recurrent energy now via the vagus. So it detects the injury from that electrocortical device. You can see that actually there is a decrease in amplitude in the monitor over there, decrease in amplitude that causes the injury that shut down the signals, and also it also detects it actually stretch related injuries. When you're seeing that actually stretch, you can see that increase in latency. Okay, that's what. So based on that, actually we can continuously use this IONM, and there's one more technique also. Maybe we can discuss later. There's a laryngeal adductor reflex that we can discuss later over the time. I'm sorry for that this confusion. Thank you very much. Yes, sir. It's a real time. We continuously do that. Yes, sir, that is also. We have one more technique also, which is called a laryngeal adductor reflex. Actually, when we do that, actually, we can stimulate the ipsilateral side of the surgery and try to, or contralateral side of the surgery of the ipsilateral superior laryngeal now, and trying to record the response from the ipsilateral side of surgery by stimulating the surface electrode itself. We are stimulating the supraglottic mucosa and trying to record the response from the vagus, recurrent laryngeal now. That connection goes through the brainstem and make sure that circuits are intact. Thank you.
Now, I would like to call on stage Dr. Deepak Sarin, who is Chairman, Head and Neck Oncology Surgery at Medanta Hospital and receiver of various accolades worldwide. Please, sir.
So with that understanding of how EMG based monitoring works for the nerves in thyroid surgery, I'll talk about how we actually use it practically intraoperatively, some of the nuances that come with it. So as we saw, there are two ways of monitoring. One is intermittent, which is you intermittently stimulate the nerve to check its function throughout the operation. And the other is continuous, where the system delivers a pulse on the vagus nerve through an electrode placed around it, and you get continuous monitoring and feedback on the nerve function as the operation goes on. The protocol to be followed if you want to keep good data is this is the international guidelines that propose this protocol, which is you record L1, V1, R1, R2, V2 and L2, which is pre-op laryngeal exam. V1 is the initial stimulation at the vagus when you start the operation. R1 is your initial levels at the recurrent nerve when you start it or identify it the first time. R2 is signals at the recurrent at the end of the operation. V2 is vagus at the end of the operation. and L2 is a post-op laryngeal exam. What we are going to use throughout the operation is looking at these three parameters, and this will tell us about the integrity of the nerve. We look at the amplitude, we look at the latency, which is the time between you stimulate the nerve and the muscle actually depolarizes, and you also look at the shape of the waveform, which is typically biphasic or sometimes triphasic in the glottis. Our targets are an amplitude of more than 500, and latency, of course, depends on which nerve you're stimulating, because the nerves run a different length of course. On the left side, the courses are longer, so you'll get a longer latency on the vagus on the left compared to the right. So V1, you expose the vagus within the carotid sheath, and we use a current of 1 milliamperes pretty much throughout the operation as our standard current. Checking V1 is critical, and what you want to see is a good signal, a good waveform. You want your initial amplitude to be more than 500. This tells you that your circuit's working well. The nerve, of course, is fine because you haven't dissected it, but your circuit's good, your machine's fine, your endotracheal tube is in position, and your depolarizing agents have probably weared off. And this then forms the baseline amplitude that you will use to compare the strength as the operation goes on and you stimulate during the surgery. You can use the nerve monitor as a locator. You would need slightly higher currents like 2 milliamperes because you're stimulating through layers of fascia. So in the anticipated area of where you think you'll find the nerve, you can use this. And if you hear the tone is a signal for the nerve, and the chirp is a false signal. Once you get a sense of where you think the nerve would be, you could open in those areas and identify the nerve. One must keep in mind that nerve IONM is not a substitute for correct identification techniques, and you may not get a signal even though you're on the nerve in many circumstances. So a negative signal is not reliable. It's the positive where the nerve stimulates which you can rely on. Once you get the nerve, you'll do your R1, that tone indicating we are correctly on the nerve, and we'll record the amplitude and the latency. And then throughout the operation, it's important you stimulate at the same point if you want to check the recurrent, because the latency would vary depending on where on the length of the nerve you're going to stimulate. So you visually mark the point where you're going to stimulate it and use the same point throughout the operation. Now, as the operation proceeds, you're going to use IONM to see are you hurting the nerve inadvertently, which is not visually evident. And one of the common sites where injury happens is when you're dissecting on the Berry's ligament for various reasons. In this video, you'll see as we work, so these are all left-sided videos, that's the recurrent running, and we've got the last part near the Berry's ligament where we need to dissect, and there are some fascial bands you can see crossing across the nerve.
Point out the band.
And as we reflect the thyroid, I'm going to relax the thyroid back into its bed. And as we reflect it, you will see this band strangulate the nerve here, that band. And that strangulation of the nerve, that may or may not be always evident to a surgeon as you're reflecting the thyroid. And what we see on the monitor as we reflected this is continuous nerve monitoring. So we're going to look at the amplitude, this is our baseline amplitude, and that's our baseline latency. As the thyroid was reflected, the amplitude dropped and dropped by 50%. A 50% drop in amplitude or greater is concerning for impending nerve injury. And there was simultaneous increase in the latency by 10%. So when you get concomitant drop in amplitude by 50% or higher and increase in latency by 10%, that's impending nerve injury. So before we work in any other part of the bed, the first thing we'll do is release this strangulating band. With persistent traction without releasing this band, concerns would be that you would end up with loss of signal and a clinically evident nerve palsy post-operatively.
Can we go faster?
And as soon as we release the band, we can see that the amplitude has returned back to baseline and the latency has now dropped to less than 10% increase. There are anatomical variations that put the nerve at risk. Extralaryngeal branching is well known, and often it's the anterior branch which is thinner, flimsier, less easy to identify, which may carry most of the important nerve fibers. In this thyroidectomy specimen, that's a big recurrent running up there. And what we have is a squiggly, spaghetti-shaped anterior branch, which if not seen, is vulnerable. So there's no signal on the big, thick, robust nerve running at the back. And the signals present on this small anterior motor branch. Sometimes you can have more than one branch. You can have multiple branches. And more than one could be carrying motor fibers. Important to preserve all these branches. Extralaryngeal branching can surprisingly be low at times. Normally it branches very close to the entry point, but this is a very, very low anterior branch. This is quite robust, but if that branch is thin and flimsy, it can be mistaken for a trachea. But we see when we stimulate it, there's a clear signal on that branch and no signal on this posterior, which is carrying mostly sensory fibers. You can sometimes be alluded to a non-recurrent nerve on the right side. This is the right side vagus.
That's the non-recurrent.
And that's a non-recurrent nerve. How you would pick this up using IONM is when you stimulate the vagus high up, you get a signal. But if you stimulate the vagus low down, you'll actually get no signal because the recurrent's already taken off before. So IONM can alert you when you do your V1 that you may have a non-recurrent nerve on the right side. It can be used as a stimulator for the external branch of the superior laryngeal nerve. You can't monitor the nerve's EMG responses because we don't have a probe in the cricothyroid muscle, but you can visually see the twitch of the muscle when you stimulate the nerve. At the end of the case, you'll do your R2, which is your recurrent signals at the end of the case. And similarly, you will do a V2, which is your vagal strength that actually checks your entire circuit and that the nerve will be functional. And then you'll record these signals in the chart. What we do is we do this, we look at the amplitude, we look at the latency, and we use the current that we were using to stimulate, which is kind of 1.0 for us now. If we are doing a central compartment dissection, we add a V3 and a R3, which are the values at the end of your central compartment dissection. If you lose signal, and the loss of signal is generally defined as a amplitude less than 100, you need to confirm if it's a true loss of signal, and Dr. Anuja will be telling you about that, how to do that and how to troubleshoot this, because the machine and the equipment does have a lot of nuances. But clinically, if you do have a true loss of signal, your concern is if you operate the other side and a bilateral thyroidectomy was planned for the case, you may land up with bilateral cord palsy, even if transient, and may necessitate airway protection or a tracheostomy. So you generally wait 20 minutes and often the signal will come back if you wait long enough. You could consider staging the operation if operating the other side is not imminent and the signal does not return even if you waited, and think of an operation, staged operation on the presumption that the nerve will eventually recover and you can tackle the other side when the mobility has returned on the first dissected side. There is interesting data that says that if you have loss of signal and the surgeon does proceed to the other side, actually the rates of cord palsy are slightly higher than what would normally happen, possibly because your mind frame is not great when you go to the other side. I'm happy to take any questions on the intraoperative use of the nerve monitoring system if there are any, or comments. Can we pull up Dr. Anuja's presentation, please? There is a question.
So if we have loss of signal on one side and we decide to go on the opposite side, are there any medical legal implications?
I don't know if I can answer that accurately. But when I've talked to surgeons around the world, there are some surgeons who are very adamant that if you have loss of signal and the operation can be staged, you must stop. But I have met many surgeons who say they actually don't necessarily stop with loss of signal. They consider many other factors. How difficult is the other side going to be? The practical applicability of bringing back this patient. If you feel fairly confident this is temporary and will recover. So it's not necessary that all surgeons will stop when you get loss of signal, but I don't know what the legal interpretation of that would be. Can you pull up Dr. Anuja's presentation?